Bismillahirrahmanirrahim. Thank you very much, Professor Mulazim, for your excellent introduction, and I'm humbled by the words you have used for me. And the topic I'm talking today is simply troponins. So I'll be talking on troponins. Let me share my presentation first. Here is my presentation. So my exact topic is troponins for the diagnosis and prevention of myocardial infarction. I've been taking this topic more recently and more about the use of troponins and in the diagnosis of myocardial infarction. But today, as the topic of our seminar is beyond diagnosis, so we will also tell you an exciting aspect of use of troponin, that is for the prevention of cardiac disease as a coronary risk marker. So let's start now. So this is my specific learning outcome that at the end of this talk, participant will be able to describe the use of troponin in the diagnosis and prevention of MI. When we were medical students, and after that, for many years, myocardial infarction was defined by WHO criteria, in which if 2 of the 3 were present, the MI was diagnosed. One criteria was prolonged chest pain, second was ECG changes, and third was serum enzymes. And in enzymes, we used to include CK, AST, and LDH. But over the years, this criteria is now obsolete and it should not be used. Lately, there has been a universal definition of MI. It is by international organizations like American Cardiac Society, etc. They have given various, over the years, various definitions of myocardial infarction. And now in August 2018, a 4th universal definition of myocardial infarction has been given. I will now read exactly what words have been used in this definition. The term acute myocardial infarction should be used when there is acute myocardial injury with clinical evidence of acute myocardial ischemia and with detection of a rise and oblique or fall of cardiac troponin values with at least one value above 99th percentile upper reference limit and at least one of the following. So presence of rise and oblique or fall of cardiac troponin is essential for the diagnosis of MI. But there may be one more thing present, and either of these 3. Symptoms of MI, new ischemic ECG changes, and imaging and evidence. So this is very important that now now troponin defines myocardial infarction. Why there can be question why we say rise and oblique or fall instead of simply saying rise of troponins. So please remember that it is to distinguish MI from other cardiac conditions. In other forms of cardiac diseases, the rise in troponins is usually constant. So right from the beginning, I must tell you that this troponin can be a diagnostic test for MI only if you demonstrate that it is not static, it is increasing or it is decreasing. Since we are dealing with a very specific disease, so we have to discuss a few words about the acute coronary syndrome. Acute coronary syndrome is a spectrum of conditions that occur due to acute myocardial ischemia or infarction. It results in abrupt reduction in blood flow through the coronary artery circulation. There are 2 main categories of ACS. One is called non-ST elevation ACS or non-STEMI. It is further divided into unstable angina and non-ST elevation myocardial infarction or NSTEMI. Unstable angina is distinguished from NSTEMI by the absence of an elevation of cardiac biomarker levels. Whereas in non-ST elevation or non-STEMI, the only or the most important diagnostic feature is rise in troponins. The other category of ACS is called ST elevation MI or STEMI, and these distinguishing features are presence of symptoms of MI and persistent ECG ST segment elevation. Rise and oblique or fall of troponins is, of course, also a distinguishing feature. Now, an important question, especially from my younger colleagues and students, troponins are more useful in which category of ACS? You can write your answers in the chat, and then we can see how far you are acquainted with this aspect. Yes, most of you are right. It is non-STEMI. Why this troponin is more useful in non-STEMI? Because in STEMI, there are, you see, I will go again to the previous slide, that you see in STEMI, there are a lot of ECG changes. There is a persistent ST elevation. So clinicians usually do not wait for the troponin result, and they start the intervention very early. Whereas in non-STEMI, since there is no ST elevation, so results of this troponins are very important, and they are main features which distinguish non-STEMI from unstable angina, because in unstable angina, the troponins are normal. So once again, I'll emphasize that in patients in which there is no ST elevation, troponins play a major diagnostic role. Now, you must have heard the term high sensitivity or HS troponin. What is HS troponin? Now, please be clear that the sensitivity or the high sensitivity here means an assay characteristic and not a different type of cardiac troponin. That means if some lab is doing the traditional troponins, or it has started doing high sensitivity troponins, the troponin is the same. It is the assay characteristic which is different. What assay characteristic? It is high analytical sensitivity. Once again, it is not clinical sensitivity. It is high analytical sensitivity, which makes it high sensitivity troponin. Analytical sensitivity, what is analytical sensitivity? It means the ability of test to measure the smallest quantity, which is called limit of detection, the low limit of detection. So, whereas the clinical sensitivity is the ability of test to diagnose, to pick the disease out of the disease population. While analytical sensitivity means the ability of test to measure the smallest quantity of that particular analyte, or lower limit of detection. Now, new generation of HS troponins has lower LOD. That is, these assays can measure low concentration of troponins. What is the difference between troponin T and troponin I? You must have heard sometimes troponin T is used, sometimes troponin I. There is hardly any difference. Cardiac troponin I is claimed to be better than cardiac troponin T in patients with renal impairment, but this is only a claim, and people who manufacture troponin T, they disown this claim. So troponin T is a propriety of Roche Diagnostic. Only Roche manufactures troponin T, while all other manufacturers make cardiac troponin I. And this is a very important point to be kept in mind, that troponin is organ specific, not disease specific. And it is raised in any disease or manipulation in heart. For example, in angiography, in angioplasty, troponin will be increased. I usually say that troponin loves heart. So any manipulation, any disturbance in heart will affect troponin, because it is cardiac troponin. It is secreted only and only from heart. So it is organ specific, but not its rise doesn't mean that patient has got MI. So that's why we use dynamically this test. That is serial monitoring, at least two results, either increasing or decreasing, or both, increasing first and then decreasing, or either of these two. So it is to distinguish other cardiac conditions like myocarditis, like cardiac tumors. uh, uh, this rise and oblique fall is used. Another term very commonly used is 99th upper reference limit or 99 percentile URL of troponin. Troponins are interpreted or reference used as 99 percentile upper reference limit. And how it is determined is determined in the disease-free reference population. We will, in a short while, we will see exactly how it is determined. The CV, or the coefficient of variation of a test, is very important, and in cardiac troponin, since it is a very important life-saving test, it is a matter of life-saving. So that's why troponin assays should be less than 10 percentile CV at the 99 percentile concentration. How 99 percentile is determined? I hope you know it, but for those who have no clue of what is how 99 percentile is determined, so it is very important that it is determined in disease-free subjects, which we call reference group. So plasma troponin assayed in these subjects, the value of troponins are listed so that the highest is at the top. The value at the 99th rank is taken as 99 percentile upper reference limit. So only one value is used. For example, we write 33.9 nanogram. And so, whereas in other tests, for example, in potassium, we use two values, 3.5 to 5. In troponin, we use only one value, which is the upper value at the 99th rank. So only one value is used. Why only upper reference value is taken? Let's see this aspect. In normal persons who are free of any cardiac disease or any cardiac manipulation, troponins are very small in concentration. They are almost undetectable. You cannot detect them. So just when one value below the highest is taken as the reference value. So then we do not take the person who has the highest value, 100 percentile, but we take just one value below it. As in statistics, you know, n-1 is usually used because we assume that might be the value at the 100th highest value might have some problem which was not diagnosed. So for safe limit we just use n-1, that is 99 percentile. However, with new generation of assays, troponins can be assayed with more accuracy in disease-free individuals. Now, there is the development of troponin assay is decreasing the LOD. So now you should be able to detect troponins in disease-free, cardiac disease-free individuals also. This diagram is very interesting and very commonly used. You see, this is our reference group or reference population who are disease-free. And this is the frequency. So, and in this axis, the x-axis, the troponin value is increasing. You see, in reference group or disease-free group, it is depicted, troponin is depicted in dotted lines because we are not sure the value of the determination of troponin is not accurate, and we cannot be sure what is the exact value. But as the value of troponin increases, the accuracy and precision also increases, and now it is depicted by the continuous line. So it is called LOD, limit of detection. Technically, it is called LOQ, but commonly we use the term LOD. So with the development of assays, what is happening that this LOD is moving towards left. So more and more disease-free individuals can be assayed, troponin can be assayed in more and more disease-free individuals with accuracy and precision. So whereas 99 percentile is a little bit right, while LOD is moving towards left. So technically speaking, if you examine this diagram, you can say that with the improvement of LOD, 99 percentile will not be changed because it deals with the higher value, while LOD deals with the lower values. So technically 99 percentile remains the same. Now, what are the two criteria of HS troponin? IFCC, which deal with mainly the chemical pathology issues or clinical chemistry issues, they have set two criteria for an assay to be called HS. One is CV at the 99 percentile should be less than 10%, as we discussed earlier. Second thing is very interesting, and that is that the assay should be able to measure the troponins at or above the assay limit of detection in more than 50% of healthy individual. That means will go again in this diagram. This is our healthy population or disease-free population. So if there are 100 people you have taken, so your test should be able to detect 50% of those individuals with accuracy and precision. So your LOD should move towards near this peak so that you can cover nearly 50% of those individuals. Only then you will call it an HS troponin. This moving of LOD towards left is very important in our, and we will discuss in our last part of our talk also. Now, these things which I am going to discuss now are cosmetically very important. And although if nobody will ask you anything, but as a pathologist or as a clinician, as a student of laboratory medicine, you must follow the international guidelines. IFCC has recommended that troponin should be reported in whole number. That means instead of using 33.9, 33.4, you should use a whole number. And unit should be nanogram per liter. Nanogram, to distinguish it from the older assay, which should be reported in microgram per liter or nanogram per ml. And in these assays, you can use 3 decimal points. While in HS assays, they should be reported without decimal points. And it should be reported in nanogram per liter. Now, next is, what are the 99 percentile upper reference limits in Pakistan population? There may be some other studies also, but we have done it about very recently. This paper was published in 2020. This paper was published in 2020 and last part of 2020. And my trainee in Rahman Medical Institute, Peshawar, Dr. Kulsoom, she worked hard on this topic, and she determined high sensitivity cardiac troponin 99 percentile upper reference limit in healthy population, and this was published in an impact factor journal. So what she determined that overall 99 percentile upper reference limit is 33.9, while in males it should be 38.41, and in female it is 15.73. You can either use the single value or you can use gender specific values too. Now, you will say why we have used decimals here, whereas the recommendation is not to use decimals, because here we want to be more specific, more precise, because these are the cutoff limits. Otherwise, when reporting patient results, you should not use decimals. In quality control, of course, you can use decimals, but for patient reporting, it should be single value. For example, if it is 33.1, you may write 33. If it comes 33.9, you can write 34. Now comes another very important question. Should laboratories continue CKMB assays along with troponins? No. We do not need wasting of budget on CKMB because there is hardly any situation. I don't think there may be a situation where troponin is not helpful and you have to use CKMB. Previously, it was said that in a reinfarction case, since troponin is already high, So CKMB may be useful. But studies have shown that in a reinfarction also, the troponin peak once again increases, and you can very easily diagnose the reinfarction. So funds should be diverted only and only to troponins. And this is textbook knowledge, Teet's textbook of clinical chemistry. Troponins are now assayed in laboratories by chemiluminescence autoanalyzers, and various firms they offer cloud-based analysis. For example, Maglumi of SNIBE China, their assay is very useful, very good, and I personal experience to that, and the results are marvelous. Architect Abbott is also good. Cobas 6000, Advia, they all offer cloud-based troponin assays. Now, as troponin are point of care assays are also available, and there are two types of point of care or bedside assays. One is qualitative, the other is quantitative. In quantitative, high sensitivity has also been offered. First, let me examine what is qualitative POCT. Qualitative POC means if two lines are present, they are positive. If one line is present, it is negative, and no line is present, it is invalid. It is very commonly used, especially in our small cities and villages. You can buy this kit from a medical store and do it yourself. But I think it should not be used, because and the method used is called immunochromatography technique. Why it should not be used? Because it is positive only when levels of troponins are very high. So it's a very poor sensitivity. So what about those patients in which it is high enough for the diagnosis, but not high enough for being positive in a POCT device? We cannot diagnose acute MI with qualitative. Why we require quantitative test? Because how can one line, two line demonstrate rise and oblique or fall? We have seen in our definition that troponins increasing or decreasing or both, it is essential for the diagnosis. That means you need a quantitative test. You have to do serial monitoring of a quantitative test. So if a qualitative POCT is used, you cannot demonstrate rise and oblique or fall, and it is merely wastage of resources, and we should not use it. And especially in a non-STEMI, you can give a false negative, since you have no other method also for the diagnosis. ECG is usually, there are no ST elevation on ECG, and if you give a false negative, that may become a patient safety issue. Patient may die because of MI, and you have given a false negative result. So say no to one line, two line, which means qualitative POCT. Quantitative POCTs approved by IFCC 2019. They are quite available. Only one of them manufactured by Japanese. This is regarded as the HS. All other are traditional assay, but they are quantitative and they can be used very effectively. But say no to one line, two line. That means we should not use either in the emergency or anywhere, because just as I told you earlier, it may give false negative results. Now, last part of my talk is cardiac troponin I as a cardiovascular risk predictor. Now, this is very interesting, that since troponins are now made very, very sensitive, analytically sensitive, that means you can now measure a lower values of troponins also with confidence. So in individuals who are disease-free, do not have any disease, in general population, you can measure troponin with great accuracy and precision. So I will quote 3 studies which have asserted that troponins can be used in general population for risk prediction. The one study, which is called Biomarker Consortium, they had concluded that addition of troponin I to establish risk models consistently improve risk prediction in apparently healthy individuals drawn from the general population. The addition of troponin I might be particularly helpful in those more than 65 years. Troponin I determination might support the selection of those individuals who would benefit most from preventive strategies. This is European Heart Journal. This was published in 2016. And from the same study, it shows if we divide the troponin I in quantities, so you see in the first fifth value, the survival was very poor, very poor. In highest values, the survival poor. In lowest value, the fifth content, it was quite low. So you can have a continuous assay relationship. That means as the troponin value increases in a general population without disease, they are more at risk of developing cardiac disease or MI. Another study which was published in Current Atherosclerosis, troponin in cardiovascular disease prevention, updates and future direction. New generation of high sensitivity cardiac troponin assays can detect 10-fold lower concentration. Now we are entering in the era of troponin assays where the LOD has been lowered about 10-fold. So as the lowering of LOD, we can use troponins as a potential marker for prevention and management of asymptomatic cardiovascular individuals. So evidence continues to show that high sensitivity troponin is emerging as one of the most powerful prognostic biomarker for the assessment of cardiovascular disease. So as we are using CRP, we are using CRP, and we are using other markers for cardiovascular risk assessment. We can use troponins as a prognostic marker. Third study I will quote from diabetes care. In diabetic patients also, BNP, natriuretic peptide, and high sensitivity troponin, they predict cardiovascular disease in diabetics. So the name of this study is atherosclerotic risk in communities, ARIC study. They show that abnormal levels of anti-proBNP and troponins may help to distinguish individuals with high diabetes risk from those with low diabetes risk. Incremental risk prediction beyond commonly used biomarkers of risk can be achieved. So my take-home messages are: troponin assay is pivotal now in the diagnosis of MI. You cannot diagnose MI if you do not have a troponin assay. So if you have a cardiac ward, if you are working in a cardiac hospital where intervention cardiology is practiced, I don't think that you can do without a troponin assay, HS troponin assay done on a chemiluminescence or with support of some POCT, quantitative POCT. Quantitative POCT may be used in the emergency, but it should be with the backup of chemiluminescence. So chemiluminescence autoanalyzers should be used. The turnaround time is usually 1 hour, plus minus 5-10 minutes. So you can very easily use it for your diagnosis. Quantitative or bedside POCT assay may be used in emergency, but negative reports should be confirmed by lab HS troponin assay, especially in non-STEMI. Qualitative POCT assay, as I said, should not be used, and we should say no to the 1-line, 2-line. With increasing analytical sensitivity and lowering of LOD, troponins are now recommended to be used as cardiovascular risk predictor in general population. How this will be effective, how we can use it, this is still not very clear, but maybe a few years from now, you will see troponins in the along with lipid profile, along with glucose, for risk assessment in for cardiac disease. Thank you very much for your patient listening, and any questions can be asked at the end of the second talk. Thank you very much, SNIBE, and thank you very much, Professor Mulazim. That's all from my side.